this knowledge is increasingly being used to develop new therapies. As I'm sure you all know, James Parkinson was a physician and geologist who lived in London in the 18th century, 18th and early 19th century, and he described the most characteristic features of Parkinson's disease as involuntary tremulous motion with lessened muscular power in parts not in action and even when supported. That's what you're seeing here. So if the patient grabs the apple, the tremor stops, and if it lays down the hand again, the tremor slowly starts again. He also considered the other features with a propensity to bend the trunk forward, to pass from a walking to a running pace. Senses and intellect are okay. So many of you will know what he's talking about because there are many, I assume there are many patients in the audience. And here's another video that shows the major motor symptoms. So the small step gait, the stoop posture, the insecurity in turning, and the rest tremor that you can see here on the right-hand side. Now, those motor symptoms develop because neurons of the so-called substantia nigra of a certain brain area, here from a normal brain, degenerate, and this can be seen here. And there, this is where the dopamine neurons are located, and they release their dopamine in other parts of the brain in the so-called basal ganglia. And the lack of this dopamine in the Parkinson patient is the direct cause of the motor symptoms. Now, this has been elucidated over the past 100 years or so, and Arvid Carlsson was the scientist who received a Nobel Prize in 2000 to identify the role of dopamine in animals. He used mice to see that dopamine is needed to allow for a normal movement. And relatively close to that, two scientists from Austria, Walter Birkmeyer and Ole Honikewicz, found the use of levodopa, so the immediate precursor of dopamine, as a treatment for the motor symptoms of Parkinson's disease in patients. So that is all 60, 70 years ago, and it has made life, one has to say, for Parkinson's patients much better. But of course, we know that there are still many things that need to be addressed. Part of it is that the pathology is not really restricted to this dopamine system. Now, when Parkinson's disease was discovered, and early in the 20th century, the specific changes, the so-called Lewy bodies, were discovered by Friedrich Levy. His name was Friedrich Levy. He was a German physician and neuropathologist. Then he had to emigrate to the United States in the Nazi era, and then he called himself Frederick Lewy. So we can say Lewy bodies for the characteristic inclusions that he found that were typical for Parkinson's disease. So it does indicate that there is probably a specific set of causes for this neurodegeneration, for this dying of the neurons. However, and that was only early in the 2000s, another German neuroanatomist at that time, Heiko Brag, discovered that those Lewy bodies are not restricted to the dopamine neurons of the substantia nigra. In fact, they first appear lower in the brainstem and in the olfactory neurons, and then only later in the development of the disease, they reach the substantia nigra and the dopamine neurons, and then later they go to the cortical areas. So there is an ascending pattern of distribution of this pathology in the brain. And this is probably the reason why there are other symptoms, non-motor symptoms, that are prominent even before the typical motor symptoms appear. And one of those symptoms, and many of you will also know that, is a loss of smell or a decrease of the ability to smell and to distinguish smells. That is because those neurons in the olfactory bulb are affected by the pathology. And another typical very early symptom is what is called the REM sleep behavior disorder. It's a particular type of sleep disorder where patients act out their dreams and they become violently thrashing around during their sleep. So overall, the course of Parkinson's disease is now today seen as a very long disease with a long duration of premotor symptoms. So it's long before the first signs of tremor, the first signs of small stepped gait and so on develop, with a loss of smell, with some other symptoms like constipation, this REM sleep behavior disorder. And only after about 10 to 15 years, then the motor symptoms slowly appear. And that is usually when the diagnosis is made of Parkinson's disease. And then, of course, as you also know, the motor symptoms become better. They're usually treated very well, at least for a long time, with dopamine replacement. But eventually the symptoms lead to more and more motor disability. Now, in recent years, it has become clear that, or a new discovery was made, that we can demonstrate this changes of certain Parkinson's disease specific features, exactly the aggregation of proteins in the Lewy bodies, if we analyze the central nervous system fluid, so the CNS of the patients, and we can probably make this diagnosis even before the motor symptoms appear. And that will become important later when we learn more about the genetic causes of Parkinson's disease, because of course the ideal situation would be if we could make the diagnosis of somebody who will develop Parkinson's disease and treat the cause that we identify by the genetic features even before the motor symptoms have started. And by that, hopefully prevent the outbreak of the clinical disease altogether. Now, what I haven't talked about yet is what causes those dopaminergic neurons to degenerate and to malfunction. And for a long time, particularly in the 1980s, it was thought that Parkinson's disease was the consequence of an intoxication. And the reason for that was that a toxin that is called MPTP was discovered that was used by people who were trying to fabricate illicit drugs, illicit opioids, and that is a side compound. And they developed a form of Parkinson's, and that has also been demonstrated in animals. So if you give this toxin to animals, they develop very similar akinetic symptoms and a degeneration of the dopamine neurons. So that was one hypothesis back in the 1980s. However, around the same time, or only slightly later, in 1990, Larry Golby and Roger Duvazien, then in the US, published a family, and here you can see the family tree with all the black symbols representing the affecteds in this family. And in this family, Parkinson's disease appear to be inherited in what is called an autosomal dominant fashion. So 50% of the children of an affected person carry the disease themselves. So that is a typical autosomal dominant pedigree. And here I show you a video of one of the patients from this pedigree. And you can see slowness of movement here in the hands and in the fingers. And you can also see that this patient is relatively young. That is typical for patients with this type of inherited Parkinson's disease. They have an average onset of 44 years, but they also have a rapid progression. They have common cognitive disturbances, so they often get demented relatively early in the disease. So it's a really, really bad and severe form of Parkinson's disease, which is inherited in this large family. Now, at that time, back in the 1990s, it became possible to identify genes that cause inherited diseases like that are inherited from generation to generation by a new method that was called linkage mapping. So what the scientists did for that method was they looked in the entire genome, so all the chromosomes from chromosome 1 to chromosome 22 and the X and the Y chromosome. They tried to find which part of the chromosomes is shared by all the affected of a large family. And Bob Nussbaum, then a scientist at the NIH in the US, did a study in this family, and he found that a certain fragment of chromosome number 4 was indeed shared by all affecteds in this large family. And there were about 15 or 20 affecteds that he could analyze, and he could see that they all had the same part of the chromosome 4. And then the next step was in this short arm of the short segment of the chromosome 4, he sequenced all the genes that are located there and found that a specific mutation that changes just a single amino acid in a protein that is called alpha-synuclein was mutated in all patients. Now, this alpha-synuclein turned out to be a very important protein in Parkinson's disease because he found that this alpha-synuclein is the basic component of these Lewy bodies that I showed you, that Frederick Lewy or Friedrich Levy discovered in 1917 already, that are characteristic of all patients with Parkinson's disease. So at that time, that was in 1996, it seemed very easy and it sounded like we had solved the problem, or Bob Nussbaum had solved the problem. Alpha-synuclein is mutated. Alpha-synuclein then forms these aggregates, these pathologic protein inclusions in the nerve cells, and that damages the nerve cells and causes Parkinson's disease. Now, of course, it was not so simple, because it turned out that alpha-synuclein mutations are very, very rare. Less than 1% of all patients with Parkinson's disease have mutations in the alpha-synuclein gene, but almost all patients have those typical alpha-synuclein aggregates. So there must be other causes that lead alpha-synuclein to aggregate and to damage the neurons. What are those other causes? Well, that is where many, many groups worked on over the past 20 or 30 years to identify a large number of genes that all can lead to Parkinson's disease. Now, a large number, we can see its number has gone up to about 25. Not all of them are true genes, but many of them are. Overall, we have more than 20,000 genes. We have about 20 genes or so that contribute to inherited Parkinson's disease. So compared to the total number of genes, this is still a small number. But what is important is that those discoveries have led us to understand some of the major molecular mechanisms that lead to Parkinson's disease. And I will not go into all the teeny-weeny details of that, but just highlight some of the major aspects. It shows that the protein aggregations, or the clumping of the proteins in the cells, are important. It also shows that mitochondria, so the energy producing organelles in the cells, are important. And it shows that the sorting and the transport of the little vesicles within the cells is important. And lysosomal function stands for the degradation of damaged cellular components. The lysosomes are basically the trash cans of the cell, and a decreased lysosomal function means that the cell cannot get rid of all the damaged material that it has to get rid of, because such a cell, particularly a neuron, has to live the entire lifespan of a human, because those cells are not replicating, they're not dividing, so they have to live during the entire lifetime of a human. And so it is very important that whenever there is any debris that accumulates, they can get rid of that debris very well, and this is damaged by other of those mutations. And I will go through some of those discoveries and show how the patients differ who have those different mutations. Because it turned out, as you probably also know, not all Parkinson's patients are the same. Every Parkinson patient has his own Parkinson's disease, basically. But there are some specific features that carriers of individual mutations have. Now, the first group of genes that was discovered after of synuclein were those that cause recessive early onset forms of Parkinson's disease. Now, what is that? Recessive inheritance means that two parents have both two copies of the gene, one damaged copy and one healthy copy. One damaged copy doesn't do any harm. That can usually be tolerated well in a recessive disease. Only if an offspring, a child of these two parents, inherits both damaged versions of the gene, then they develop the disease. But they develop the disease very early, and that is the specific feature of these recessive early onset forms of Parkinson's. We have already 3 different forms that are usually analyzed. One is called Parkin, one is called Pink1, and one is called DJ1. You don't have to remember all those gene names. They all have similar features. They have very early onset and have a relatively benign development. They also have a specific molecular cause. Those patients, and I mentioned that, have a damaged quality control of the mitochondria, so of the energy producing organelles in the cell. What's important is that those patients, I mentioned it, have a slow course of the disease, but they do develop fairly severe motor complications, and particularly severe dyskinesias, while being cognitively perfectly okay for many, many years. I'll show you a video of one patient of ours, a young patient, onset 35 years. So typical early onset Parkinson's disease. And you can see here, when he's taking levodopa, he develops this very severe motor dyskinesias, hyperkinesias of his movements. And this patient has undergone deep brain stimulation treatment. And you can see that in a minute. And the next video, you can see that he has a slightly dystonic posture of his hand. But here he stands up, he walks with large steps, with good arm swing. So he benefited very well from the deep brain stimulation. So in young patients, particularly in those with those recessive early onset mutations, deep brain stimulation, because the patients have to live for a very long time with the disease, deep brain stimulation is a good opportunity and a good way to treat them. Another form of Parkinson's disease is caused by a gene that is called LRRK2. That's another important, or turned out to be an important form of Parkinson's disease. It's again a dominant disease. So it is inherited from one generation to the next. As you can see here, there's a great-grandmother that is, or great-grandfather that is affected. Then there are 5 affected in the next generation. There are 2, 4, 6, 7 affected in the next generation, and so on. So it's going from one generation to the next. I'll skip that. And in this family, in these families, and in similar families, 2 groups, the group of Andy Singleton and my group, found the responsible gene, the LRRK2 gene, as we call it, LRRK2, that causes the disease in those subset of patients. Now, I already mentioned, so this is quite similar in terms of genetic inheritance to the alpha-synuclein, to the first gene that I introduced. But we now have some important differences. I mentioned that the alpha-synuclein mutations are extremely rare. There's not more than a couple of dozen worldwide of patients with that mutation. I also mentioned that those patients have a relatively severe, the alpha-synuclein patients have a relatively severe form of Parkinson's with early onset, with severe cognitive impairment and dementia. Now, this is a patient with a LRRK2 mutation. And what you can see here, she's at that time of the video, she's already 64. She had an onset at 55, so it's a bit on the early side, but not unusually early. She's only treated with a dopamine agonist, with pramipexole. And we see her in this video. And she has perfectly fine motor skills. She is cognitively very well. She has a MoCA test of 29. You know, this is one of those cognitive tests that can go up to 30. So 30 is the maximum, and she has 29. So she's almost perfect in this test. And she has a LRRK2 mutation. So the LRRK2 mutation is a relatively benign mutation, at least very often. But it's also a common mutation. Here is the frequency of patients with LRRK2 mutations worldwide in different regions of the world. So in Germany, Northern Europe, it's not that common. Only about 2% of Parkinson patients carry this mutation. But in Southern Europe, it's already a bit more common. There's about 7%. And where it's particularly common is in Ashkenazi Jewish individuals and in North African Arabs. They have about 30%, so almost every third of Parkinson patients in these countries carry the LRRK2 G2019S mutation. And this is probably because this mutation arose first time about 2,000 years ago. It's probably, there probably is also an advantage to carry that mutation because it may protect against diseases like tuberculosis. And so this mutation was carried on from generation to generation and became relatively common in this population. So the age of onset I mentioned is variable, but is almost like the Parkinson's patients without mutations. It's a mean of 59 years, so almost 60 years, but with a wide variability. So that's an age of onset distribution of a large group of patients. So some are very young, they are 20s, in their 20s when they start. Some are very old, in their 80s or 90s, but the majority are in their 50s and 60s to develop this disease. This mutation is a mutation that changes the activity of the encoded protein. Now, for that, we have to realize what the protein does. And this protein is an enzyme that is called a kinase. So a kinase is a protein that modifies other proteins. And the activity of this kinase influences many functions of the cell. So it influences the degradation of debris in the cell. It influences the mitochondrial energy metabolism and so on. And the mutation, particularly the G2019S mutation, makes the kinase, the activity of this enzyme, overactive. And that is a target for potential therapies because overactive kinases can be inhibited by so-called kinase inhibitors. Those are drugs that have usually been developed for cancer chemotherapies because kinase activity also plays a major role in the development of cancer. But in this case, they also can be used, and they are used clinically in clinical trials to slow the progression of Parkinson's disease. And there are some studies by Denali and Biogen, by those companies, who develop and test LRRK2 kinase inhibitors in Parkinson patients with the mutation, but also in some Parkinson patients without the specific mutation, because the pathway that is overactive in those patients is common to all Parkinson's patients. All right, so that was the third gene. So we had alpha-synuclein, we had the recessive genes, the Parkin and PINK1, and we had the LRRK2 gene. Now, the fourth gene that I would like to draw your attention to and explain is a gene that has been known for a long time, but it was not known that it has any role in Parkinson's disease. It was a gene that causes a childhood onset neurodevelopmental disease that is called Gaucher's disease. And there are different types of Gaucher's disease. There are symptoms like an enlargement of the liver and the spleen. There are some patients who develop neurologic symptoms, and it's a recessive disorder. Now, you remember what I said about recessive diseases. Recessive diseases develop when both mutated copies of a gene are passed on to one child from both parents who carry this who carry one copy of the mutated gene. Now, earlier in the talk, I told you one copy is usually compensated for and it doesn't cause any disease. Well, in this case, this is wrong. It turned out, and that was discovered really by Ellen Sidransky and others at the Gaucher clinics at the NIH, that heterozygous carriers, so those parents who carry one damaged copy of those genes each, they are at an increased risk to develop Parkinson's disease. So the children with both mutations, both genes mutated, have Gaucher's disease. The parents who are carriers of one mutation and have another healthy copy of the gene, they have an increased risk to develop Parkinson's disease. And you can see here the risk, depending on the type of the mutation, the risk is increased by a factor of 3 up to 20. So a factor of 3 is not too much, but an increase of factor of 20 is a lot. There's another interesting aspect to those patients who have mutations in the GBA gene, in the glucocerebrosidase gene, which is encoded by the GBA gene. they have a more severe and more rapidly progressive form of Parkinson's disease. Here you can see a schematic. This is the typical Parkinson patient. This is a patient with a LRRK2 mutation. I already told you that they have a more benign and more slowly progressive form of the disease, but those with a GBA mutation have a more rapidly progressive and more severe form of Parkinson's, a little bit like those with the alpha-synuclein mutation. Now, I showed you examples of those other mutations of those patients, and I also showed you an example of a GBA mutation carrier. This is this patient at the time of the video. He's 70 years old. He developed the disease at 60, but he already has a relatively severe disease, even though he takes a lot of levodopa. So it's 950 milligrams of levodopa, but he developed severe Parkinsonian symptoms, and he also developed severe non-motor symptoms like cognitive impairment. So his MoCA test, remember 30 is the maximum you can achieve. The less you have, the more cognitive impairment. He's down to 14. And he also has frequent hallucinations and orthostatic dysfunction, so blood pressure regulation problems. So it's a severe disease with a lot of non-motor forms of symptoms. And he has such a GBA mutation, a Gaucher disease gene mutation. What does this gene do? It encodes a protein that is called glucocerebrosidase. And this protein is a protein that is important, plays an important function in an organelle that is called the lysosome. I already mentioned the lysosome. It's the trash can of the cell. So the GCase, the protein, gets transported, gets accumulated in this trash can, and there it helps to degrade the synuclein, the protein that forms the synuclein aggregates, by a certain mechanism that is called glucocerebrosidase function. So it cleaves certain glycosyl sugars, glycosylceramide, and by this process keeps the lysosome functioning. And if this GCase, the glucocerebrosidase function, is not sufficient, then the synuclein also cannot be degraded in those lysosomes, and it aggregates in the form of Lewy bodies. So that's what we currently think is the mechanism of the function of the GBA mutations. And a number of clinical trials have already been done. For example, by a drug called venglustat, a glucosylceramide synthase inhibitor that would reduce the substrate concentration, so the compound that usually gets cleaved by the glucocerebrosidase. That study was not successful. It was a study done by the company Sanofi that was not successful. But there are other drugs, for example, Ambroxol, that is activating the glucocerebrosidase activity that is remaining in those patients, that is activating the glucocerebrosidase activity, and that might be useful in slowing down again the progression of the disease. And this is explored in a number of studies. So there are a number of studies that are currently underway that use Ambroxol and different preparations to slow the progression of Parkinson's disease. So I'd like to summarize what I told you so far about the genetic forms of Parkinson's disease. And that is, as we have seen, that they are very heterogeneous. Sound up. that they are quite heterogeneous. We had a patient with an early onset recessive form. We had a patient with a synuclein mutation. There's another patient with a GBA mutation, and there's a patient. Oops, turn the sound. Yeah, and there's a patient with a LRRK2 mutation, and they all have different pathologies. So they differ slightly but distinctively in their pathologic changes of their brain. So it means that each of those types probably have to be treated differently. And I mentioned some of the studies that are already ongoing with the different types of genetic forms of Parkinson's disease. Now, overall, those with genetic forms are basically only the tip of the iceberg. About 10 to 15% of all patients, all Parkinson patients, carry mutations in one of the genes that I have described so far. The vast majority, that would be the iceberg under the water, are patients without explainable or explaining mutations in one of those genes. But genes also play a role even in those patients. And in the remaining 5 minutes or so, I will just touch a little bit on this genetic contribution to sporadic Parkinson's disease. That is a little less practically useful as of now, but will probably become important in the future. An important thing to know is that we all differ in our genomes at many, many sites. So I mentioned that we have about 3 billion base pairs overall in our genome with about 20,000 genes, but we are distinguished by hundreds of thousands of variants in the genome. So we all differ. And some of the variants, and those variants are called SNPs, single nucleotide variants. Some of them are common. And so everybody has a different base pair or a different building block at this position. And some of them are rare. On average, every 500, 1,000 base pairs, there's a difference from one person to the next. And this difference is used to distinguish between patients and controls. And this is a relatively simple form of analysis. So those variants differ in frequency in different populations, different groups. And if you discover a variant that is usually in the general population less common or has a distribution frequency of 40 to 60%, but in patients, this distribution is different. So if a patient has only fewer of one building block base pair SNP than a healthy control, then you can assume that this variant is involved in conveying the risk to develop Parkinson's disease. And those studies have been done in large and very large collaborations, and you don't have to really understand this graph. This is just a graph that shows from chromosome 1 to chromosome 22 all the genetic regions that contain SNPs, genetic variants that influence the risk of the disease. And if you look closely, you can see that all those variants, or many of those variants, have also been already mentioned in the 4 genes that I mentioned as typical Mendelian genes or inherited forms of Parkinson's disease, like GBA, like alpha-synuclein, the abbreviation is SNCA, like LRRK2. So overall, the genetic architecture of Parkinson's disease can be explained by either rare or relatively rare variants that have a strong effect, or common variants that have a mild effect on developing the disease. And I have already mentioned the 4 genes, the alpha-synuclein, the PARC and PINK1, those are the recessive genes, the LRRK2, and the intermediate risk variants like GBA, glucocerebrosidase, and the LRRK2 G2019S variant. That is the common mutation that occurs in the Ashkenazi Jewish and Arab population. So to sum it up altogether, of course, genes are not everything. Genes play an important role, and they play an important role as the typical Parkinson's disease genes that I mentioned, the LRRK2, the GBA, but also as risk variants in the vast majority of sporadic patients. And overall, we think that the total influence of the heritability of genes is about 25 or 30%. But we also know that environmental contributions are important. We don't exactly know what that is. So maybe head trauma at an early age, at a young adult age, may be important. Maybe pesticides may be important. Interestingly, caffeine and nicotine appear to be protective. So smokers develop less commonly Parkinson's disease. And in the end, of course, we don't know if there are any other factors like infection or bad luck that leads to some people developing the disease and others don't. But the genetic proportion is about 25 to 30%. And in those patients, it is important that we know that we can develop drugs that specifically interact with those pathways, and that may slow the progression of the disease or may, even if used early enough, may prevent the development of the disease altogether. And again, those are mostly Parkins, so that's for the early onset recessive one, alpha-synuclein and GBA for those with the severe forms of Parkinson's, with a lot of dementia and autonomic failure, and LRRK2 as a gene that causes a relatively mild form of Parkinson's disease. And with that, I'd like to conclude and come to an end and give you the opportunity to ask questions. Thank you very much for your attention. I'll stop my screen sharing, right?
All right. Thank you, Dr. Gasser. I think that's all the questions that we have. Thank you for presenting with us today, and I think everyone quite enjoyed it. So yes,
thank you very much for your attention, and I'm happy if I could give you a bit more insight into the genetic underpinnings of Parkinson's.